finishes. But what we were able to do is that now if the data is in meds by October 15th, instead of September 15th, October 15th now, they will go directly into managed care. They will have the full 60-day choice process. If the data and the enrollee is in meds by November 15th, they will still go into managed care on the 1st, and they will have a truncated, shorter notice process, about 3 weeks choice process as opposed to 60 days. And this is allowed for in the ABX 11 legislation under the process for late enrollees. But with those two dates, now it's not September 15th, it's really, we're encouraging everybody to try to get their data into meds by October 15th because we think the choice process, having adequate time to make a choice is very important. But at the same time, we're trying to balance that with the continuity of care of getting folks into managed care on day one. So this should get the great and vast majority of folks into managed care on January 1st. And there is, I mentioned that some work we still need to do is about what happens after November 15th and what is the process and what are the timelines and are there still mechanisms we can use to get folks into managed care on January 1st, even when people come in after November 15th, and we will be working on that. And that's all I have for that section. Thank you.
So now I'm going to talk a bit about the actual communication outreach process, including some of the noticing information that Brian just shared. So in essence, it's important to think about there are kind of different aspects of the communication outreach process. One is this process of using communications to allow for plan assignment, make sure that people are getting the information necessary. But we're also doing quite a bit of work, including this process here, establishing convening meetings to inform stakeholders about the process, but we'll also be developing regional meetings that will be used to interface with community-based organizations and local stakeholders so they're aware of how to help their LIHP clients either in the MCE, the Medicaid expansion population, or in the Healthcare Coverage Initiative expansion population that will be moving into covered California on how to navigate that system. And we'll be providing a curriculum and examples to help those community-based organizations work with their clients effectively. And we've asked the LIHPs in the local areas to help us with that process as well. So we'll be doing a set of community regional meetings in the fall. So first I wanted to start with noticing. So as Brian mentioned, we have several notices related to plan choice, but really we have 3 core notices for the LIHP Medicaid expansion population. So these are informational notices that will be general in nature. They're available in Appendix A of the LIHP Transition Plan, and the language is already provided, but we're accepting feedback up until yesterday related to that. But if you send in late feedback, we can, of course, try to integrate it, but we can't guarantee it because of the tight timelines. In essence, there's 2 separate notices in that appendix, one for county-operated health system counties and one for non-county-operated health system counties, knowing that the processes work very differently depending on what type of county you're in around plan choice and enrollment and how that PCP assignment would work. So we're anticipating that that general LIHP notice would go out to all LIHP Medicaid expansion beneficiaries from the LIHP themselves, co-branded with DHCS in late September, saying some pretty basic information around the key themes of the transition and the requirements going forward. So it'll provide an introduction to the transition, inform people that they'll be transitioning to Medi-Cal even if they take no action, that the transition will be occurring on January 1st, 2014. But one important aspect is to make sure that people know they need to maintain their LIHP eligibility. So if they have a redetermination date coming up, let's say in a county that decides not to do the deferred redetermination or in September, or if they just missed a deadline or something like that, that they need to make sure they're eligible and active in LIHP prior to the transition, or it won't actually happen. So it'll be important to notice that. So this will be distributed by the LIHPs in September. Then you have 2 other notices specifically for the MCE population. One is this plan choice notice that Brian just went through. We also call it the 60-day notice, in that it would come out November 1st or before, related to identifying the plans that contain your low-income health program assigned medical home and would reinforce those key themes of make sure you keep your LIP enrollment active. You will transition on January 1st, 2014, and that there is no action necessary in order to pick a plan. You would just be auto-assigned based on your LIP medical home, as well as what plans are available that contain that LIP medical home, and no additional action would be required. So it'll provide, with that plan choice notice, there will be documentation around the networks for the managed care plans in the area, and it would provide instructions on that choice if you didn't want to stay with the LIP medical home and the managed care plan that potentially would be assigned to you, or the choices that would be assigned to you. Then there's a 30-day notice, which Brian alluded to, which is specifically for people who haven't chosen a plan at that point, or haven't responded at all to that 60-day notice, as well as it serves as the first notice for people in that late enrollee pool. So this will be the first notice that people get around plan choice, and the fact that they would stay with their medical home through a new managed care plan January 1st if they showed up in meds after October 15th but before November 15th. Both of these notices need to contain language related to appeals and other things that CMS will require, and so the language for these notices hasn't been released yet because we're waiting on some guidance around how that would work. In addition, we have a notice specifically for the HCCI population. So this is designed for people converting into covered California rather than moving into Medicaid expansion population. And of course, we have no guarantee that they will actually transition because of the fact that they would have to go through the MAGI determination through covered California and CalHERS. They would have to decide on a plan. They would have to decide to take or not take advanced premium tax credits, and then actually sign up for that plan by December 15th in order for that to be active January 1st, according to exchange policy. So we're working with the exchange, or Covered California, to figure out what the notice would look like, and how they are going to contact that population and try to inform them and help enroll them. So we're integrating tasks there. In addition, so that's the fourth notice, but it's one that's just for the HCCI population. So 3 notices for MCE, 1 for HCCI. But we acknowledge the fact that the low-income health programs themselves need information to help them make this transition with their clients. And so we provided an Appendix F of the LIP transition document, frequently asked questions list that we've been getting feedback on, that we'll be perfecting and putting up on the website, as well as delivering to the, well, maybe not perfecting, I saw Brian shake his head, because nothing's ever perfect in our world at this point, but will be disseminated to the counties so they can use that as talking points and as guidance for helping their clients understand the process, helping their social services departments understand the process, help their county providers understand the process as well. In addition, after those notices and that FAQ are finalized, there will be communications coming from Medi-Cal directly related to, that aren't notices but are a welcome to Medi-Cal packet and a beneficiary identification card and information sheet, with the welcome to Medi-Cal packet being delivered when somebody is enrolled into a managed care plan or when they've been confirmed as a fee-for-service because of the late enrollment. And a week later, the beneficiary ID card that entitles people to fee-for-service coverage would come, and then those assigned to a Medi-Cal Managed Care Plan would be informed to wait for their Medi-Cal Managed Care card to arrive so that they can start using the managed care services as well. And so there will be those 2 communications for everyone that makes the transition in the MCE population, and then we would anticipate additional communication coming from the managed care plan themselves, because they're going to have to send out the beneficiary's managed care enrollment card for whichever plan they were assigned, whatever PCP they ended up with, as well as information on the summary of benefits and how to navigate that process. So at that point, they would be a full-fledged managed care enrollee and would use those services. We acknowledge that some customization will be needed by counties, and so we're working with individual counties that want to add information to their notices or potentially use language provided in the notices for additional communication for specific populations, to inform people about where they're assigned within the county medical home and when they would have to get a change in to switch things around while they're still in the LIP, as well as how to get access to support during the LIP program. So from a communication standpoint and help in the transition, it's important to remember that during the up until December 31st, 2013, anything related to LIHP eligibility and enrollment and services still has to go through the county LIHPs. They'll send that one general notice informing them of the changes, but then they basically are running their program as is until December when it ends and hands off responsibility over to Medi-Cal. Medi-Cal will be dealing with eligibility issues through the local Medi-Cal offices, through the ombudsman, as well as through healthcare options, which will be responsible for getting the calls and assigning people into medical homes and managed care plans by request. So those communications will be reviewed by DHCS to make sure they, comply with all the legal obligations that DHCS has, and that they focus on this transition and support the transition. So any additional communications related to transition will have to be sent through DHCS, through the LIHP Transition Project email, or directly to Brian or members of the team. So those are the communication issues. In addition, we acknowledge that providers will have to be given information, as well as those community-based organizations. So we'll be staging 4 to 6 regional meetings supported by the Blue Shield of California Foundation. That will be 3 to 4 hours each. The first one will be August 28th in LA in Alhambra, September 5th in Oakland at California Endowment, September 11th in Sacramento here at the Convention Center, the week of September 26th in the Central Valley, possibly October 1st in San Diego, and then we're reviewing venues for a Reading meeting that would occur in early October. So we're trying to cover all the different regions in the state to make sure that the community groups can come get information on how this would work and get some coaching on how that would work. And it'll be staffed by UCLA, UC Berkeley, and DHCS staff, as well as representatives of the local LIHPs. In addition, we'll be developing a series of provider-focused webinars to train people live and enable them to review recordings later on various topics within the transition. So we might end up developing webinars that are very basic around the Medi-Cal plan assignment issues, but also on special populations, how to work with the homeless population, the HIV/AIDS population, continuity of care issues. So we're anticipating that there will be a series of these webinars that would probably last an hour to an hour and a half each. They would be live broadcast for people to attend, but we would then store a copy and it would be posted on a consumer-friendly LIHP Transition website. We're developing the Transition to 2014 website that'll be available in August so that people can come on, review those webinars, get information, send it to their friends who are interested, get information on the FAQ documents, what the notices say, and the entire process as a whole. So you can see it's kind of a multi-pronged communication effort, allowing for customization, but delivering the information as necessary to the LIHP transition population. So this can be a fairly seamless process, but also providing enough information for stakeholders at the local and the state level to help people navigate the process and hopefully make an effective transition.
Hello again. So I'm going to talk a little bit about continuity of care with you. I think many of you are aware of what continuity of care is, so I'll just start off by saying that this is a very important issue for the department, and we are committed to ensuring that enrollees and beneficiaries obtain continuity of care where appropriate, and that there are not breaks in, or gaps in services. In terms of what the department looks to for requirements for continuity of care, there are 2 sections of the Code of Regulations that we reference. The first is Welfare and Institutions Code Section 14185. This piece of the code has to do with prior authorizations for prescriptions. In particular, I would note that it really establishes requirements pertaining to timely access for prescriptions if the enrollee shows up. So, for example, this question was asked yesterday. If an enrollee shows up on January 2nd and has a prescription that's not on the formulary, how is that processed? And so this part of the section of the code really references what the requirements are for the health plans in terms of how quickly they need to authorize the prescription, what they need to do in terms of if there's an emergency situation. It also enforces or establishes the requirement that the health plan is is required to continue any prior authorization, at least until the enrollee or beneficiary is able to get in to see a provider at the plan. And so if there's a prescription in place, that will be continued until the provider with the health plan is able to see the enrollee. The second piece of the health code that we really look to is Health and Safety Code 1373.96. And I would encourage you to look at this part of the code. It is really it's a large set of language, but it really calls out different types of continuity of care. So it might talk about pregnancy, it might talk about surgery, care for individuals who have terminal illness. It highlights for each of those different areas what's the timeline and what's the requirement for the plan in terms of how long do they need to continue continuity of care. Another place, just in terms of recommendations, if you're looking for additional information about continuity of care, you might look to our managed care boilerplate contracts. There's information there, as well as we do have all plan letters related to continuity of care as well, which further clarifies what language is included in our contracts. And I would note that we do have a continuity of care all plan letter that's currently under review. I thank many of you in the audience for, I think, all 50 pages of comments that we received, and so we are going through all of those right now and ensuring that we look at each of your comments to make sure that we incorporate them as appropriate, and we will be sending that back out for another look prior to issuing it, just to make sure that it's pretty lengthy and it addresses all the different populations. In the future, we'll be adding the low-income health program to that document as well. Brian talked a little bit about the fact that we know that right now today our provider matches show that about 90% of people, or more than 90%, will likely stay with their same medical home as they shift from the low-income health program to Medi-Cal Managed Care. I think as we continue to do the provider matches, we hope to increase that percentage, and likely we'll see an increase. We will be working with the health plans, and so after we've completed those matches, we will be providing a list to the health plans of those medical homes that the enrollees are assigned to under the low-income health program. And in particular, this is important because we want the health plans to be able to use that information to take a look at their networks to understand if there are areas that they need to bring additional medical homes into the network to ensure continuity of care. I would note, the one thing I wanted to note before I move on and talk a little bit about the data that I mentioned earlier today, in the transition plan, we did not actually reference that there is also a requirement that enrollees may request up to 12 months of continuity of care with a specialist provider. That's something that will include, or I'll look to Brian to talk a little bit about how we might, I don't know if we'll be updating the plan, but I just wanted to make sure that I mentioned that because it was inadvertently left out, and that information should have been in there. I talked earlier a little bit about the data and how important it is to provide the data, and that we'll be giving health plans information data 30 days prior to the date of coverage beginning, so 30 days prior to January 1. For this population, that would mean we would be providing utilization data that's been collected by the low-income health program to the health plans. We also will be facilitating a process between the LIHPs and the Medi-Cal Managed Care Plans, which will allow them to share prior authorization data to ensure that that information is provided to the health plans so that they have it once the individuals come in for enrollment as well. We do anticipate that we'll be issuing an all-plan letter about this. So I should have said this before, I think most of you are familiar that the all-plan letter is used really to set forth what requirements we expect the plans to come into compliance with. And so we'll be issuing an all-plan letter about this in the near future. Initial health assessments are required for all beneficiaries or new enrollees within 120 days of enrollment. We do recognize, though, as Brian mentioned and I just stated, that about 90% of people will stay with their same medical home. And that means that they've been seeing this provider. That means that they've likely had a health assessment already within the last 12 months. And so if the enrollee or member stays with their same LIHP medical home as they move into Medi-Cal Managed Care, we will not be requiring a new initial health assessment for those enrollees. There are a few caveats that I would mention. The first is that an enrollee can always request to have an initial health assessment, and the provider plan is required to engage in that health assessment then if the enrollee does request it. The other thing is if there's a change in life circumstances, health plans today are required to conduct another initial health assessment if there's a change in life circumstances. So that would also be a caveat in terms of if the enrollee comes in, they go in to see the provider identifies there's been a change through talking with them and looking at the initial health assessment information that they have from the LIHP, then they would go ahead and conduct another one. For that less than 10% that won't stay with their medical home, we will be requiring that they do conduct, the health plans do conduct a new health assessment within 120 days, which, as I said, is the current contractual requirement. So, as I mentioned also earlier, it's really important for us to know what's happening in terms of the transition of the population. So we will be also requiring health plans to submit quarterly reports to us in terms of the experience that they are having with the population, the LIHP population. And so examples of information that we do collect are continuity of care. We collect grievances and appeals, call center information. And this really tells us the story of what's happening and allows us to identify if there's any issues that we need to talk with the plans about, or if there's anything that we as the state need to be doing on our end as well. In addition, we will also be submitting or creating an all-plan letter that will set forth those requirements as well. And I think Brian's going to talk a little bit about the benefit formulary and authorization now.
Yeah, and I won't talk too long on this because I mentioned it at the beginning of this talk, but we are, by October 2013, we will be doing an analysis of benefit formulary and authorization differences between LIHPs and Medi-Cal programs and making that information available and having a plan of how that information is going to get to beneficiaries and providers and plans and LIHPs. And also, two other things that I mentioned earlier is that we will be collaborating with Covered California to notify eligible LIHP enrollees about the coverage options through Covered California. And also just wanted to mention that those two welfare and institutions, or the Welfare and Institutions Code section and the Health and Safety Code section that we referred to about continuity of prescriptions and continuity of services also apply to plans that deliver services through Covered California. So folks transitioning into those plans can count on those guarantees as well. And then the last thing that I did mention earlier is that we have more work to do. We've definitely identified that there will be special populations who are hard to get information to or have complex conditions that will be critical during this transition, including folks receiving care for mental health conditions, HIV and AIDS, folks who are homeless, who are difficult to outreach to, and as we mentioned, more work on a process of sharing information for people who have open authorizations for services that will be happening around the transition period. And I think that's all we have.
Okay, I'd like, excuse me, I'd like to open it up now for the questions and answer period. So you can come up to the mics and form a line, and we'll take your questions for any of the issues that were discussed today in this panel, as well as Sarah Brooks' earlier panel about lessons learned.
Hi there, I'm RF Sheikh with Cal Optima. My question, I think, is for Alice. This is regarding the redetermination once the transition takes place. I was unclear about that. Will that be different from a normal Medi-Cal enrollee, or would that be a different process?
It's not going to be a different process. This process, once they become Medi-Cal beneficiaries, they will be required to comply with all Medicaid rules, so that if the redetermination is due in a specific month, they would be notified far in advance to get that information in. So it's no different from the current population.
Thank you.
Welcome.
Okay, please.
Hi, Abby Corsall with the National Health Law Program. First, just a comment. We're really pleased that it was an oversight that the option to request up to 12 months of continuity of care was left out of the draft that went out a few weeks ago. But we would like to, again, encourage DHCS to consider expanding that option to include ancillary services, DME. That was a huge area where we saw a lot of need in the SPD transition, and we anticipate that there will be a need for continuity of care with those providers in this transition as well. So we urge you to consider that. And I also have a question regarding the guidance that you're expecting from CMS that will influence the plan choice notices. I was wondering if you could tell us a little bit more about what that guidance will entail.
Yeah, just a little bit. By and large, I'll just say that we think we're mostly on track with the information that we're planning to include in the notice, but CMS has a checklist of 8 or 9 things, and part of it will be figuring out, we definitely will need to include all of the things that are in that, but where we include them and how we include them, which notice, what venue, those types of things. So, you know, things like benefit differences have to be noticed, but is that, you know, which notice or how do we do that is a question we have to continue working on. Things about appeal rights, which are a little bit tricky given this population and the ending of the program, and what's the appeal for, and how do we deal with that, and who sends it, and which notices it in. So those are some of the things we're just going to be working out, but don't anticipate any significant changes.
So just as a follow-up, are you expecting some kind of formal guidance from CMS, or is this just part of your ongoing negotiations?
So CMS has mentioned that they will be putting out model notices that would include this. Also, there is a PowerPoint presentation that CMS has put out wherein they list some of the key pieces of information that they'd like to see, both in transition plans and in the notices. And that was one of the slides that Gloria had up, was copied from that PowerPoint. So yeah. The model notices, those are supposed to be out soon, but we're not really waiting for them. We're, I think, going to put out the rest of our notices for stakeholder feedback, and that includes CMS feedback very soon. And we'll just get that. We'll get that feedback person to person. And our clock is ticking. So.
Thank you.
So.
Okay. Participant number 1.
Hey there. I had a question for Brian. You mentioned that the Medi-Cal Managed Care benefits overall more robust than the LIHP plan, but that some benefits might not transfer. What type of benefits are you talking about?
So again, we will be having more information on that benefit analysis. And could you just identify yourself for the webinar
David Gordon,
audience?
California Healthline.
Okay, great.
Yeah.
And this is Brian Hansen. So certain optional benefits, LIHPs had the opportunity to include, and there may be cases where certain counties included things like podiatry or other optional benefits that are not broadly available in Medi-Cal, although they are available in some instances.
Okay. So not ABA therapy, autism, like the Healthy Families issue, because it sounds really similar.
No, and
Okay.
we are trying to be clear that but the continuity of services and continuity of care applies to things that are available in Medi-Cal. So,
Oh, and when is the FAQ going to go out to physicians? Do you know? Maybe more for.
more like November, I'm going to say.
Okay.
Yeah.
Is that right?
Well, I mean, we have the model FAQ posted already that's more focused on counties. However, I think it would be useful for physicians as well, because it describes what Medi-Cal is, what the transition is, how it'll work. But we'll probably end up with a more targeted set of questions related to continuity issues and initial health assessments and that type of thing that'll come out of the training and the webinars we're doing in the fall of 2013, targeted to physicians and their staff.
Thank you.
Hi, Edie Ernst with Private Essential Access Community Hospitals. We're very supportive of the focus on continuity of care. We're also supportive of MC enrollees being fully informed of their provider networks and their plan options. So to that end, I had a question about the provider notices, the 60-day notices. Will that include the entire plan network provider list, or is that just a portion of it? If you could clarify.
Yes, our plan is to send the entire choice packet with those 60-day notices, so people would have full information about
So all
the availability of
contracted
provider networks in